we're going to talk about one of our most feared complications, and that is the occurrence of an intraoperative, perioperative spinal cord injury. And for that, Michael Fehlings will talk about what should I do next. So, Michael.
Yeah, thank you, Brian, and it's a pleasure to take part in this symposium. So, this is a feared complication. It's probably happened to every single person in this room. It's happened to me. I think we need to destigmatize this. We need to talk about it, and we need to kind of establish a protocol. So I don't have any relevant disclosures related to this talk. So I'm going to talk about pathophysiology, some prevention strategies, stress or role of intraoperative monitoring, how to recognize this, and some management strategies. These are just a couple of references from some of my own work in this field. So just as a heads up, so Brian Kwan and I are actually chairing an AO Spine Praxis Guidelines group on acute spinal cord injury management. 3 topics. One is an update on the role and timing of surgery. We'll be strengthening those recommendations. Some optimal hemodynamic management will be updating the 2013 guidelines. And then importantly, for the first time, there'll be a guideline on the prevention, diagnosis, and management of intraoperative spinal cord injury. So I'm going to share a few of those pearls with you. So here's kind of an example of a high-risk case. Fortunately, I did not have an intraoperative injury in her, but this is somebody that you got to watch out for. She's got OPLL, severe cord compression, progressive myelopathy. You got to watch out here. So what happens, in the initial events after an intraoperative injury? You're going to have hemorrhage. There'll be mechanical injury. There'll be early inflammation, edema, pro-inflammatory cytokine release, and importantly, compromised vascular supply. So we need to think about, okay, what can we actually do, to deal with this? And then we need to understand the cascade of events of secondary injury, and the vascular events are absolutely key, and I'll come to this, as is inflammation. So we recognize that autoregulation of spinal cord blood flow is disrupted. There are critical zones of ischemia. In the 2013 guidelines that we'll be nuancing and revising a bit, but essentially the principles are to bump the mean arterial pressure to try to maintain cord perfusion. So prevention is the key, so recognition up front. So unstable spine, compressive myelopathy, cervical or thoracic cord are bad actors. If there's a potential for intraoperative hypotension, trying to prevent this, if you're correcting a deformity, if you're resecting a vertebral body. So fiber optic intubation for patients with cervical instability, careful positioning, maintenance of mean arterial pressures, multimodality intraoperative monitoring is really the only way, practically, that you're going to pick this up. So, these are the types of cases that you're going to want to use these modalities in: careful positioning and avoidance of distraction. So, what can you do pharmacologically? We have limited options. A potential option to consider preoperatively and perioperatively is the use of riluzole, as we described in last year's Lancet Neurology article, and there's some secondary analyses that are underway suggesting that, in fact, this might actually attenuate some of the perioperative neurological issues. So in terms of neurophysiological monitoring, this is from our own experience. Of course, we have somatosensory evoked responses, so these monitor dorsal columns as well as dorsal spinocerebellar pathways. We have a number of EMG approaches. Most commonly, it's free-running EMG. Then, of course, motor evoked potentials. So here's an example. This is kind of a complicated case. It's a syndromic neurofibromatosis case with cervical thoracic deformity. And essentially, when we were doing some of the work at the cervical thoracic junction, we had high burst EMG activity from C8, and the action was to widen the foraminotomy. Patient awoke with a mild C8 deficit, which then recovered. And then, this has been replicated in the deformity field. This is a systematic review from 2010, where essentially it was recommended at that time that multimodality electrophysiologic monitoring be undertaken. But the knowledge gap that was recognized at that point was that there really weren't well-established protocols. Okay, fine, you have this, so what do you do with this information? And so this is now where we're updating these guidelines. So this is kind of work in progress. So this will be coming out in publication in the new year in the Global Spine Journal. But these are forest plots of sensitivity and specificity of prospective high-quality articles in the field. And you'll see in the table on the right that multimodality monitoring is around 90% sensitive, and about 95% specific. And so I think the idea in the past that, you know, the information wasn't of particular value, wasn't very accurate, I think that's old-fashioned information. It's accurate, you need to act on it. Okay, so what do you do if this occurs? So you'll see a sudden change in MEPs, SCPs, rule out technical or anesthetic issues, think about what you did, stay calm, but everybody needs to focus on the issue. Manage. Is there anything that you did that maybe you can reverse? Maybe with some hardware that maybe wasn't optimally placed, maybe you did a distraction, reduction maneuver, just ease off on that. Raise the blood pressure, consider inotropes, whether it's dopamine or levofed or some other option, and consider steroids. And yes, use methylprednisolone. Okay, that will target one of the factors, which is inflammation. Okay, so raise the blood pressure and give an anti-inflammatory drug. So post-operatively, do a careful neurologic exam, get some imaging. If there's a problem, deal with it. Earlier is better. Give steroids if you feel that the patient will tolerate it. Map parameters, and then an option is subarachnoid drainage of CSF. Brian actually studied this in a trial. The effects were a bit equivocal, but you know, it's an option to consider. Okay. So these are the 2017 AO Spine guidelines. Okay, and the reason we did this was that the field went from, it was kind of the standard of care of everybody, and then it was like the worst poison in the world, which is absolutely ridiculous. It's not borne out by the evidence, and it's an option. And I can tell you, if you're in the operating room, these guidelines will save your bacon. Okay, so you want to use the steroids. So these are the forest plots, and there is a positive effect. It's modest, but you know, we don't have a lot of options. It does not increase mortality. It does not increase mortality. In fact, the trends are reduction in mortality. Okay. And so the current recommendations are that it's an option and it's valid to use, and you now have, you know, a guideline here to back you up in terms of its potential use. So it's kind of a care pathway that we're developing. So the first step is the initial clinical assessment. Recognize this, have a proper informed consent. Document the neurologic exam carefully. Step 2, have a multidisciplinary discussion, speak to anesthesia, optimize anything you possibly can preoperatively. The patient's anemic, whatever you can do to try to optimize that. Step 3, surgical and anesthetic planning. We would recommend the use of care pathways or use your own care pathway, multidisciplinary discussion. This is the time to use the intraoperative monitoring. And then step 4, have an approach in terms of what happens. And I'll show you kind of a bit of a care pathway that we've adopted from the published literature. And then post-operatively, document an accurate exam, have a monitored bed, get imaging, use steroids, and watch the hemodynamics. Okay, so a few points. I can't go over all of this, but one is have an intraoperative pause. All extraneous conversations, stop. You're playing music, stop it. Get control of the operating room. Everyone needs to focus on this. Stay calm. Okay, this is not the time to have a freak out and throw things. It's not going to help anything. Okay, it happens to all of us. Most of these injuries will improve. Okay, figure out what happened. What can you do to correct it? Speak to the monitoring people. Rule out technical issues. Speak to anesthesia. Optimize your hemodynamics. Optimize your parameters, and then consider intraoperative steroids. So this is a team effort. This happens to all of us. We need to destigmatize this. It doesn't mean you're a bad surgeon. Trust me, it's happened to me. It's happened to every single person in this room. I can assure you of that. Okay? Recognize the high-risk cases. Avoid hypotension. Multimodality monitoring is helpful. And then have an approach. Try to figure out the possible causes. You know, be calm. Think about this. What can you do to fix it at the time? And consider steroids as an option. Thank you very much.
Comment for Mike, Tim Gregory, Minneapolis. You kind of went over quickly the CSF drain, and we anecdotally have a few cases where we believe it's made a significant difference. Maybe you could talk a little bit more about it, because the thoracic spine literature on aortic aneurysms, they put them in beforehand, and it's not conclusive.
Yeah, so there's a good literature on CSF drainage to try to attenuate cord ischemia related to thoracic surgery for sure. And like Brian did a trial with it, and the idea was good. It didn't really work that great, but I think it's an option, you know, to potentially to consider, for example, in cases where you think that there might be an ischemic injury of the cord. Like it's an option you know, to consider there for sure.
Yeah, I think that you know, I think what you've kind of highlighted is the fact that the cord is exquisitely sensitive to changes in perfusion. And so, you know, there you are, you're trying to do your best to improve perfusion to the cord, and one way to do that is to lower the intrathecal pressure. And then, you know, I think that the vascular surgery literature has borne that out, and we do it routinely in our hospital in our vascular cases. I have done it. We did a prospective randomized trial pilot where we're clearly not powered to show a neurological difference, but we found that it was safe and well tolerated by the acute spinal cord injury population. So it's an area of ongoing study, but I think that you know, any of these measures to try to improve perfusion are probably, in this context, welcomed, because you know, one of the core principles of trying to manage an intraoperative / perioperative spinal cord injury is to make sure that the cord is well perfused. So, okay, thank you very much.